Hi, everyone. Thanks for joining this morning. We will get started in just a few minutes, right at 10 o'clock. But wanted to let everyone know our live stream has now started. And also you should be seeing the agenda for our meeting today on our screen now. So we'll get started in just a few. Thank you. Okay, good morning, everyone. This is Carly Houchin at the Kansas Health Institute. I'm showing 10 o'clock, so I will go ahead and get us started. Welcome first to this meeting of the Policy and Treatment Working Group. As a reminder, this group is coming together to put together a 10-year strategic plan for the modernization of the behavioral health system in our state. I'll go over our agenda and other meeting materials for today in just a moment, but I want to first see if I think Eileen from the Revisor's Office is able to read us the statement on open meetings.
Thanks, Carly. And here we go. Due to health and safety concerns, members of the public are not in attendance at this meeting of the Special Committee on Mental Health Modernization and Reform Working Group on Policy and Treatment, but full access to this meeting is being conducted by medium of interactive communication, allowing members of the public without cost to listen to the meeting through the use of live stream audio broadcasting on the internet and teleconferences available. The live stream of this and all other working group meetings of the special committee may be found on the Kansas Legislature YouTube channel. The agenda and documents for this meeting have been provided by the Kansas Health Institute and may be accessed on the Kansas Health Institute's website. Additionally, a link to the documents has been provided in the comment section of the YouTube feed for this meeting. Each member of the working group and staff will state their name and title each time the individual begins speaking or voting so that the individual can be readily identified by remote listeners. All participants are required to ensure that microphones, telephones, or other electronic devices are muted when the participants are not speaking so that the ability of remote listeners or observers to hear the proceedings is not unnecessarily impeded. Public comment will not be allowed at this meeting. During this meeting, the committee will not recess to a closed or executive meeting pursuant to KSA 75-4319 and amendments thereto. Finally, each motion, if any, will be clearly stated before the working group votes, and the chairperson will announce the results of the final vote. And that's all I've got, Carly.
Very good. Thank you, Eileen. So this is Carly Houchin again, the Kansas Health Institute. Will run us quickly through our agenda here today. So we'll get started with introductions. So we know who all is on the line in just a moment. Our two primary objectives for our meeting today will be reviewing priorities related to prevention and education, and as well as the topic of treatment and recovery. So at the highest level, what we're aiming to do today is get down to our handful of highest priority recommendations related to those two topics. Then, if time allows, we will dive into the topic of special populations, and what we'll be doing there is overviewing the results from the Qualtrics survey that a handful of you participated in to ensure that there is consensus on how those are scored. And then we will kind of pick that topic back up at our next meeting to get to our highest priorities there. Then might get, I think, have a few administrative updates, and we will adjourn by 11:30. So as far as materials that we have to support our meeting today, you all should have received a PDF copy of this agenda, as well as a document providing the first draft scores of the high priority or of the recommendations related to prevention and education, as well as treatment and recovery. That should be a PDF file as well. I will show our working document on the screen when we get to that portion of the agenda, but that is something that I would direct you to maybe have open on your screen as well, or have a hard copy in front of you, as that will allow you to see all of those recommendations throughout our meeting. With that, though, let's first run through some introductions so we know who's on the line. I will run through working group, regular working group members first, and we're joined by a supplemental expert again today as well. But the first person I'm seeing on the roster here is Lisa.
Hi, Lisa Southern, Executive Director with Compass Behavioral Health.
Very good. And Gary?
Gary Hinault, Director of Youth Services, KDADS.
Senator McGinn?
Hi, Senator McGinn, and I'm on the interim working group for modernization of mental health.
Very good. Candace?
Candace and I am with State Government Affairs with Cigna.
Kelly?
Kelly Hansreed, Director of Medicaid and Children's Mental Health for DCF.
And Kelsey?
Hey, Kelsey Torres, Behavioral Health Consultant in KDHE's Bureau of Family Health.
Deb?
Good morning, everyone. Deb Stidham, Kansas Association of Addiction Professionals.
And Sunny?
Hi, I'm Sunny Mickle, Vice President of Government and Community Relations for Blue Cross and Blue Shield of Kansas.
Very good. Any other working group members on the line at this point that I missed there in those introductions? Okay, not hearing any. Barbara Andres is also joining us for today's meeting. Barbara, would you be willing to unmute and tell the group a little bit about yourself and some of the background and experiences that you bring to today's discussion?
Hi, everybody. I am an executive director, have been for over 30 years. Right now, I'm with a program called Breakthrough Episcopal Social Services. I have a PhD in nonprofit management, kind of a systems expert looking at, in particular, mental health systems. Have worked with people with severe mental illnesses for most of my career, along with people who live in poverty and people with substance abuse problems.
Very good. Thank you for joining us today, Barbara. And feel free to weigh in throughout our discussion whenever you have comments to add over the course of the agenda. Okay, with that, I will take us right into our first agenda item, which is reviewing priorities for prevention and education. So let me get the right screen share going here. Okay, so what everyone should see on my screen right now is the recommendations that the group has reviewed from past groups or developed and has scored related to the topic of prevention and education. They are presented on your screen from highest combined score to lowest combined score. And what we're going to do over the next half hour or so is get to our highest priority recommendations. So to quote, I believe, a member of the special committee, if everything is a priority, nothing is a priority. So with that in mind, our goal here is to have no more than 4 or 5 recommendations per topic. And if we can get fewer than that, I think that gives even more precision to the work that we would be putting forward to the special committee. The other thing I'd like to say before we dive into that discussion is that all of this work will be preserved. The recommendations that are not considered the highest priority will all be included in the report in an appendix. So all of that work will be maintained and can be taken up whenever there's an opportunity to do so. With that, and with the thought that our goal is to get to the top 4 or 5, let me first highlight, just only going by score, what would be the top 5 on our screen, and pose the question to the group, of those that I've highlighted here in yellow, which should be removed from the highest priority category. Any of these first 5 that I'm flagging here, at first blush, we know that should not be in our highest priority category. So I'll give you a moment to read those. Any thoughts coming to mind there as far as recommendations that might not fit into that highest priority category?
This is Kelly with DCF. I'm just seeing 2 of them related to early childhood. So in my mind, if we have to eliminate one or not focus on one of those, that would make sense since they're somewhat kind of related.
Okay, so I'm seeing, Kelly, to make sure I'm looking at the right things here. So the recommendation in row 11, the CS recommendation, and then in row 13, the early intervention. Is the suggestion to combine those, or is the suggestion to kind of pick one or the other as far as a high priority?
This is Kelly from DCF. I don't know. However, if I were to choose, I would pick the line 13, recommendation 3.4 over the other one, but I mean, I don't have super strong feelings on that.
Okay, any discussion from the group if the initial suggestion, apologies there, I moved too far over. If the initial suggestion is to bump that recommendation in row 11, the CS recommendation, bump that down to an appendix, any concern with that?
Well, I would agree that the row that it talks about additional language in the plans to cover those additional services is the priority. So.
Very good.
This is Kelsey,
Okay.
KDHE. I'll just add that the Child Cabinet picked up the Family Engagement and Partnership recommendation, and they have made, I think, like a strategic plan or action plan to move that work forward. So that would happen with early childhood programs, but not specific to mental health.
This is Gary Hinault from KDADS. I would agree to keep recommendation 3.4, and that we could consider moving the CS to an appendices.
Okay, so then the other question that I might pose to the group, so we have 4 highlighted in yellow right now. Looking at the 3 that we that have not yet been highlighted, any of those definitely need to be in the running for highest priority. So we have one related to a pilot program utilizing coroner letters, a recommendation related to care management, and a recommendation related to suicide prevention. Any of those need to be kind of bumped up for early consideration in our highest priority category.
This is Barbara Andrus with Breakthrough Episcopal Social Services. I'd like to not make a recommendation, just add some information. I sat on the advisory council for the One Care program, and that is a critical program that we're still tweaking. It's not touching enough people at all, but talking about relationships and really making an impact on prevention and helping people stabilize, that's a high priority that I would just throw out there.
Thanks, Barbara. So that comment I'm reading would be related to recommendation 2.2, the care management program.
Yes.
Discussion from the working group on that. Should recommendation 2.2 be in the highest priority category?
I think as a recommendation, I support it wholeheartedly, and I think it is vital. The only thing I'm bouncing around in my head is whether that fits the definition of prevention that we've been trying to encapsulate here, or is this more about treatment? So that's the only, maybe we could move it and maybe they would find a nice little home there. I don't know. So I also had a comment about the SUD prevention. So I'm thrilled that that's there. However, I'm wondering about making that a little broader. So because really we just need to invest in prevention efforts in our state around behavioral health, because that also can include, early detection, early intervention for mental health problems. It could include, the stuff around the suicide, right? Because that's the beauty of an effective system addressing prevention, is that if suicide is a trend, right, which of course we are seeing that, but let's say it goes down, well, then maybe we don't need to invest so much in it. Maybe actually we have a problem with something else, whatever the drug trend of the day is, or whatever we're seeing, right, whether it's our youth or whatever, that we can then direct additional resources towards those issues. So I guess I'm just saying I would recommend making that one broader. So it would just be targeted funds or increased funding for prevention for behavioral health, which then it could include the bottom one there around suicide as well.
This is Kelsey with KDHE. I thought we had another recommendation that kind of is related to what Deb is speaking to right now. And from what I see on our previous crosswalk that we use, it's prevention for fund prevention. It's establish and sustain permanent funding sources for primary, secondary, tertiary prevention. I'm not sure what happened with that recommendation. I don't know if we merged that with something else or if it just didn't score high enough, but I feel like that's exactly what Deb's speaking to.
Yeah, this is Carly at KHI. I'm in the process of pulling notes up there on that prevention for recommendation, so I can get you that background information in just a moment. To address the initial comment from Deb, I think I maybe heard two options there. Is the group interested to rewrite the recommendation in row 14 to more broadly speak to the need to utilize additional state funds? And oops, my screen got sorted. So are we interested to rewrite the recommendation in row 14 to be more broad about the need to utilize state funds around kind of whatever prevention efforts are most pressing of the day? That's option one. Or I couldn't tell for sure, but maybe there was a suggestion in there too that the suicide prevention recommendation should be moved up to a high priority. So are we interested to rewrite recommendation in row 14 to be about prevention more broadly, or are we interested to upvote the suicide prevention recommendation to specifically address the issues of SUD and suicide prevention? Discussion from the group there?
This is Deb Stidham again. So did we figure out what happened to that other recommendation, Carly?
Yeah, in the process of pulling that up still. So okay. I'll fill the group in.
Because I'm wondering that, I mean, you hit a larger target with a broader one, then you run the risk of losing something specific that you wanted. I don't want to lose the suicide prevention piece because that's such a pressing problem. And I also absolutely love that we had a sentence in here about increasing the number of individuals certified in prevention. So that seems, that would definitely get lost in the shuffle if that wasn't listed.
Okay, so this is Carly at KHI. Apologies for the delay there. The prevention for recommendation, the group decided to combine that with the new recommendation that was written. And I can't tell from the page of my notes that I'm looking at. So it looks like the group thought that was covered, and either the recommendation to expand resources to make sure there's a network of support around the 988 funding, or if the group considered that as part of the SUD prevention, and that the SUD prevention piece was the piece that needed to be highlighted. So it looks like the decision from the group in a previous meeting was to strike the broader recommendation with the idea that it would maybe be more a more clear directive to maintain the specificity. I don't know if those comments are helpful for anyone in kind of reminding us where we'd been in conversation previously, but that's what I've got in my notes.
Okay, so I found what Kelsey was talking about. Deb Stidham here. Establish and sustain permanent funding sources for primary, secondary. Is that the one, Kelsey? And tertiary. So it is kind of the same thing. I mean, and so that one was not written broader. It was very specific to SUD prevention. So.
And so this is Carla at KHI. The decision that the group had made related to that recommendation in a previous meeting was that that recommendation was covered, I think.
Yeah, I can see that.
Yeah. So
the other one wasn't. So the hope was that we had a broader one. It really isn't broader. So what you're saying, Carly, is that the one at the bottom there about the information dissemination about suicide prevention really is captured with the 988 funding and everything that would include. Is that?
No, sorry.
Okay, I misunderstood, sorry.
Yeah, before I was trying to
Okay.
go back through my notes quickly to identify what the group had decided related to that prevention 4 recommendation that had been struck.
Got it.
So I think that the decision is still on the table. Is the group interested to give kind of topic specific directive to, like in these recommendations related to SUD prevention and suicide prevention, specifically calling both of those out? Or is the group interested to combine those and translate it into a broader recommendation about utilizing state funds around prevention? I think that's the decision on the table right now for the group.
This is Kelly with DCF. I would vote for the broader prevention. You know, if we prevent trauma and things like that, then that would then in turn prevent SUD issues and things like that. So I would vote for extended prevention.
Okay, so this is Carly at KHI. I think I've heard that a couple of times. So we will plan to edit what we have in row 14 here to be about broader behavioral health prevention efforts. We will maintain the language, or I feel like I'm hearing from the group, utilize, we want to continue to recommend that we utilize state funds for, and I'm going to say here, behavioral health prevention. And as an example, to mention the 2 specific issues that the previous recommendations maintained, we'll list both of those there. And then I'll keep this second part of the language here unless the group directs me otherwise. So the second part is including funds to support an increase in the number of individuals certified in prevention in the state. Does the group want to keep that language, or should that be struck in the interest of keeping this specific to funding around broader behavioral health prevention efforts?
This is Kelly with DCF. I would recommend what you just mentioned, the broader prevention efforts.
This is Gary Hinault, KDADS. I agree with Kelly.
Okay.
I think some people might, we start out talking about behavioral health prevention, and then I think people might be somewhat confused by, are we then just talking about SUD prevention, but we're talking about the broader.
Very good. Thank you, Gary. So now I'm going to switch gears a little bit. Let me mark these in a different way. Let me do outside border and then okay, so those 4 are the ones that you all have been talking about as our highest priority. So we're going to maintain that. An additional, I guess, request from the special committee is that this work be considered a living document. And so with that, there's interest to have kind of clear action steps for approximately, the number that's been tossed out is for approximately the next 2 years, as well as guidance around a strategic direction for the next 10 years. Recognizing that there will be a need to be flexible as changes occur over that period. So looking at these 4 recommendations here that the group has flagged as high priority, what we would like to do at this point is flag those, and I'll color them in yellow, the ones that should be considered for immediate action. And that means that this change should be completed in the next 2 years. The other option that we'll flag the ones in green, the recommendations that we will consider of strategic importance. And by that, we mean recommendations for which work should start now, but it will take years to implement, and it will kind of take more of a concerted effort over a longer period of time to get that recommendation implemented. So a brief definition of those 2 are at the bottom of my screen there. But what I would propose that we do is go one by one, and we'll color each box either yellow or green. So the first one that we'll look at is the recommendation related to 988 funding. And so it reads, once the 988 National Suicide Prevention Lifeline phone number is implemented, Kansas should collect fees via phone bills to support increasing the in-state answer rate and to ensure that callers are connected to in-state resources. Would we consider this recommendation one that requires immediate action, meaning that this change should be completed in the next 2 years? Or is it more one of strategic importance that will be completed over a longer time period?
Kelly from DCF, I would say yellow immediate.
Gary from KDADS, I'd say yellow.
I don't think the 988 number starts until 2022.
But Gary from KDADS, my
Okay.
concern is that it's going to take legislative action.
Okay.
And that really probably needs to start now so that we have it in place.
Okay, that makes sense.
Okay, heard from a couple of people there that one should be yellow. We'll pause to see if there's any concern with that designation. Okay, not hearing any. The next recommendation in row 13, 3.4 related to early intervention, reads increase access to early childhood mental health services by including additional language in the state Medicaid behavioral health plans to explicitly cover early childhood mental health screening, assessment, and treatment. Do we consider this a recommendation that would require immediate action, meaning it could be changed, the change could be completed in the next 2 years? Or is this more a recommendation of strategic importance that we should kind of start the legwork now, but this one will take a little longer?
This is Senator Pat Petty, and I would put it yellow, immediate action. We have interest in early childhood in the legislature. It certainly fits into what we've been attempting to do for the last 4 years.
Great, thank you, Senator Petty. Discussion from the group on that?
Deb Stidham, I agree. I think it's should be something fairly obtainable quickly if there's the will.
Okay, then I will take us to the next one. This is, and apologies for the language, we'll get this cleaned up before you see it for final approval. But this is the recommendation that we've just slightly modified the language to be about broader funding for prevention efforts around behavioral health. So about utilizing state funds for that purpose. The group want to consider this one as one for immediate action, or is this more a recommendation of strategic importance that will take a while?
Deb Stidham, I think this will take a while. I would also suggest adding something in there about increasing the level of state funds. There are state funds now attached to SUD prevention. It's the minimum that's required from the federal government for the block grant. And so that's really the point. We've never invested in it in this state.
Okay, made that change. Any discussion from the group there on labeling that one as one of strategic importance? Okay, seeing nodding heads generally. The last recommendation that you'd kind of flagged as an initial high priority here is the one related to a centralized authority. So this is for a centralized coordination of behavioral health, including substance use disorder and mental health. So centralized coordination of behavioral health policy and provider education in a cabinet level position. So discussion from the group, would we consider this one as one for immediate action or of strategic importance?
Just Deb Stidham. I just want to say I absolutely adore this recommendation.
Happy to have recommendations people are excited about. That means we're on the right track. Any preference for the group as to how we label this one? Is it one that can be completed in the next 2 years, or is this more of a strategic shift that will take some time to implement?
Probably go ahead and get started then if that's it.
This is Gary at KDADS. I think we could go green with this one.
Looks like most of the people.
Okay, discussion from the group on that?
Okay.
We're really looking forward to it. We got to hear.
I guess I agree that probably green is the more prudent response. I'm thinking about kind of a couple things. Striking while the iron's hot. We're investing, I figured it out, 50 hours of our time between August and December towards this effort. We've got, a governor that's in play for at least another 2.5 years. I think we can all agree that the field has been neglected. I mean, certainly as long as I've been in it, the only time we've ever paid attention is when we have problems, right? Our jails are full. So let's devote money to SUD outpatient treatment just for the offender population. Oh, we have suicides. Now let's focus on suicide, which we still haven't done, probably enough for sure. And then, just the whole mental health piece. We have active shooters, we have XYZ problems. And so we better devote our attention to mental health. But we've never had sustainable cabinet level position to just keep this moving forward. And I think that's one of the things that I hear everybody's interested in is some sort of sustainability out of this. What's going to sustain administration interest? I don't know. That's my 2 cents.
I would have to agree. I think we have the opportunity, and I think this would be, the governor has expressed a lot of interest in mental health, and of course it fits her background as well. But this is a positive. I think it's a yellow.
Okay, hearing from a couple voices there, that this one should be considered one for immediate action. Any other concern or discussion from the group on that?
Not on that, but I was going back to that 9-8. This is Lisa with Compass. Sorry. The 988 number, the projected start date for that is July 2022. So that might, I think it might be worth adding on there so that they understand our time frame to get this up and running.
Good point. Very good point. Thank you, Senator Petty.
And this is Gary from KDADS. I agree with the last one being yellow. I kind of feel like they should all be yellow, but felt like we should put something in green.
Very good. This is Carly at KHI. So Lisa, I've added that to our rationale note, so we'll be sure that's noted for them in the table that they have that context for that start date. Okay. That gets us to a set of high priority recommendations here. We'll give you all a minute to look at those together and see if there is anything missing from this high priority set before we move on to our next topic.
This is Deb Stidham. Were we going to consider the recommendation around care management for treatment section?
Thank you for reminding me. Yes, so I'm gonna go ahead and change the label on this one so that we see it in our next topic in just a moment. Okay. Not hearing any other discussion on prevention and education, we'll the next time you see these four, it will be in something like a product format for your review. With that, I will take us to treatment and recovery. Try and get all of these on the screen at one time here. So it'll be a little bit small in order to see them all at once. So I'll direct you to kind of page 2 of that PDF I sent around. That's where you should have them all at a more comfortable font size, with the exception of the one that we just have moved here, which is recommendation 2.2 related to care management. So let me get this sorted by score. And again, we have the same goal. So we want to get to 4 or 5 of our highest priority recommendations related to treatment and recovery. If we went just by score, it would be 1, 2, 3, 4, 5. It would be these first 5. So want to first see if we can create some space in that top group there. Any of these not quite striking working group members as highest priority, that maybe should be moved to that appendix for kind of items to take up at a later time. So any that can be removed from this top group.
I guess the one that jumps, this Deb Stidham, that jumps out at me is the frontline capacity. I mean, again, it's certainly not a bad recommendation. I don't know if somebody on the group can speak to that a little bit more so that I can understand what the intention was. Like, what would they do exactly? So what's a pediatrician gonna do? Is it just a screening and referral? So I'm just,
This is Kelsey of KHI. I can speak to it a little bit. We currently have 2 different like workforce development grants in this area. So one is targeting youth and the other is targeting pregnant and postpartum women. So both of those federally funded programs are geared towards increasing that frontline provider capacity so they can treat individuals within their clinical practice, opposed to like overloading our already stretched mental health system. So by providing more of an early intervention, you know, through like well child checks or anything like that, they may not continue to increase like that level of severity.
so are you talking about the actual, so I'm just trying to envision this. So it's a pediatrician, they're doing probably an assessment during that visit. Are they referring them to somebody down the hall that's trained in mental health, or what are they, what's the intervention and by whom?
So it depends on the practice, but most of our clinics that we're working with, the physician themselves would be providing that treatment. So opposed to like if it becomes like a need for therapy or something like that, that's being referred on to an appropriate treatment provider. As far as like medication practices, we see a lot of that come in, and what we do is provide support to those physicians to make sure they're following appropriate prescribing practices. Because, you know, like we see there's not a lot of training in this area for them. So we want to make sure that it's being done correctly, but they're following best practice through support network. Does that
so the expansion of the care they're providing is around their medication?
Mostly, yes.
Okay, all right, that's starting to make more sense to me.
Yeah.
Is this, Carly, you're involved in all the work groups, right? Would this fit under workforce?
The issue I would raise for the group about moving something to workforce at this point is that group already had their meeting like this on that workforce topic.
Okay.
So that would be the challenge there.
Okay.
So just to follow up on this discussion on frontline capacity, is the group interested for this one to be considered in the highest priority? Or is it something that should be maintained in an appendix for a group to take up at a later time?
This is Gary from KDADS. I still think it needs to be in a higher priority. You know, the expanded behavioral health needs of those frontline those providers is huge. When you think about the numbers of children who've been suicidal or completed suicide, all of them basically were seen by a pediatrician or someone other than a behavioral health provider shortly before that. The national statistics show. So I really think that that's where we're going to need to have, more than just meds, but additional training for those providers to identify those folks and get them the help they need.
Senator Petty, I'm just wondering if within that one, should there be any reference to the fact about the grant that's presently that is presently being funded through KDHE? Or
This is Kelsey with KDHE. I know that was noted on like the initial recommendation sheet, so I don't know if that supports the recommendations as they move forward or if we need to note it here. I'll kind of defer to Carly on that.
Yeah, thanks, Kelsey. We have those notes. Not all of them have been dropped into this rationale column, but that will be included in a reference on the report. Lisa, did you have a thought there? I see you unmuted.
Well, yeah, I sorry, I had to step out and go to the bathroom. So I hope I didn't miss anything. But how do we engage them? Like, what is their incentive to participate in training? Just being a CMS provider, a Medicaid contract? I guess I'm just wondering how, we make this an objective, but how do we get those people to actually do this?
This is Kelsey with KDHE. Lisa, I'm assuming you're referring to the frontline providers. Yes, okay. Just wanted to make sure before I started talking, and that's not what you meant. So what we've seen so far is pediatricians especially are almost desperate for information. Like these kiddos are coming into their practice as it is, and they're struggling to meet the need. They don't know what to do. So what we've established is a consultation line that includes a social worker, a pediatrician, a child and adolescent psychologist, and a child and adolescent psychiatrist. So pediatrician, family physician, whoever can call in, staff the case with this team, who then provides best practice recommendations for treatment of child and family. So within the first year, I think we've been up and going, after implementation, within 6 months, we've enrolled, I want to say 80 or so primary care physicians. And the consultation line has been accessed over 100 times. So there's definitely a need, and there's a lot of areas of the state that the team just hasn't been able to reach out to for recruitment and to increase awareness of their support services so far.
This is Senator
I'm so sorry.
And this would certainly match with what we just highlighted in yellow under prevention and education about recommendations for early intervention.
Thank you, Senator Petty. Was there someone else looking to weigh in there?
Hi, this is Sunny Mickle from Blue Cross of Kansas. I had a question for Kelsey, and I was wondering if she's also seeing that they're having children with private insurance coverage needing the same services. So is this an opportunity also to make sure that private insurers are working with the program, or also able to coordinate with KDHE on this program?
This is Kelsey with KDHE. I want to say yes, but I'm going to pull up our data sheet real quick and then I'll respond to that, Sunny.
This is Carly at KHI. I'll plan to add to our rationale and notes there that we want to be sure that, Sunny, if I'm interpreting your comment correctly, we want to ensure there's collaboration with private insurance on this effort.
Correct. Thank you.
Okay. While Kelsey is pulling up that data sheet, I did want to flag for the group related to the recommendation TR1, expand MAT, or medication assisted treatment. When the finance and sustainability group met on workforce, I just wanted to make you aware that they considered a recommendation related to MAT as a highest priority. And that recommendation was something to the effect of increased capacity and access to medication-assisted treatment in Kansas through provider training on MAT. So just want to flag that for the group in case that changes in any way, how you consider the recommendation that you have here related to that topic, or similar to that topic, as far as expanding MAT. So I guess the decision for the group there is this an important component that we should be sure to address in treatment and recovery? Or is there a different recommendation that you would like to move up to this high priority in place of this recommendation on MAT, with the thought that there's a recommendation related to that topic elsewhere? Okay, not hearing from anyone there. We'll leave it as is. Kelsey, were you able to pull up that information on the?
It wasn't, and unfortunately, it doesn't look like they're asking that question of everyone that's calling in. So what our data is showing is 17% are Medicaid and 83% unknown. So not super helpful.
Okay.
But I agree, like with Sunny, that should be encouraged as this moves forward.
Very good. So then, oh, go ahead.
Oh, I was just going to, in looking at all of these, when I looked at, and of course I don't have all the background, so we could just keep that in mind. But when you look at service array, that's up there in the yellow, explore options to expand the behavioral health service array. And then you look at all of the items that aren't in the yellow. They're kind of part of the service array that aren't hitting the priority levels. So on the top, we're talking about that we want better access of services for people, but we're not making top priority the desperate need on the front line to really enhance services like housing services, homeless services, supportive employment. So is there somewhere else in this plan where that's going to come up as an important thing, because those services were the ones that were really cut back on when we cut back in the mental health system. So I didn't know if there was a different way to write that, or if I'm just not seeing that correctly.
This is Carly at KHI. If the group's interested to add in perhaps the rationale related to the service array recommendation, some of the specific services that that you all would like to flag as an important part of what it would mean to expand the service array, that would be one option.
This is Deb Stidham. I guess, I'm here representing substance use disorder, mostly treatment. And I can tell you that to call what is available for SUD treatment in this state a service array would not really reflect what it is. I mean, it's bare bones, it's acute services primarily and only. There, compared, if we don't think there's enough service array on the mental health side, I can assure you that we're still in kindergarten on the SUD side. So I hesitate to bring in all those other things to this when, in my lens, I'm very excited to see this here because I think this calls out, services that are desperately needed across whether you're insured or not insured, right? We just don't have enough SUD services. We're just at the bare bones. So I hear what you're saying, Barbara. I don't know if some of that's elsewhere in the committee, in the workforce, not the workforce, the task force in general, or not, but.
Well, I'm just wondering, with service array and connecting it that everybody should have access to it when we don't have a service array, that maybe putting the people in the service array together. I mean, it doesn't matter if you make it a priority to have more people access poor services and then have your services underneath. So I just don't know how to make that. There's just so much to do. I don't know how to integrate that in this plan. That's the problem.
I agree with that.
Yeah.
Very good. So this is Carly at KHI. I think I'm hearing that, you know, while it's not a perfect option, we're generally liking the service array recommendation kind of as is. Want to also raise the question to the group, any of the recommendations not highlighted in yellow that should be upvoted to this highest priority designation. And I'll say we need to do a 1 in 1 out. So if we're moving any of these up, we would need to downvote something we currently have in yellow.
Deb Stidham, just going back to the highlighted, I think you could combine the MAT with the service array as long as we call out something in there, like I really like expansion of MAT in block grant services as part of that service array. Frankly, you're not going to get any traction in the SUD system without increasing the block grant funded system. So that's my recommendation, and that would free up one spot.
So I can make that change, but want to ask the group, is there something that something else that needs to be added to this highest priority group in the spot that Deb's freed up for us there?
So Barbara, which is it? Sorry, Deb Stidham. Care management program or supported housing?
It's a hard decision. Do you want people to be healthy or do you want them to have a place to stay?
This is Kelsey of KHI. I'm curious if we could combine the SOAR with the housing. They are definitely two separate programs, but because SOAR has a homelessness component to it, I didn't know if it would be appropriate to merge those two together. Or since there are two different programs, we need to keep them separated. Someone who's like more familiar with that work might be able to weigh in on that.
And this is Carly at KHI, and to clarify, would we be talking about combining the recommendation to continue and expand housing first, or expand the supported housing program?
I would say supported housing, because housing first is something that can come under that as a way to implement it. So supportive housing is probably a better way of looking at it.
Okay, so any concern from the group with combining expansion of the supported housing program in with this high priority recommendation related to the SOAR program? Any concern from the group with that change? Okay, not hearing any. We'll plan to add the expand supported housing recommendation.
Would there be a way of maybe moving supported employment up into the array of services along with the MAT?
Discussion from the group on that. The idea was to move the recommendation related to supported employment as to one that's specifically mentioned in the high priority recommendation related to the service array. And I'd maybe specifically be interested to hear from Deb, since you'd weighed in on this recommendation previously.
You know, there's acute care services, and then there's all the ancillary services that help support the progress that's made, hopefully in acute care. And it almost feels like two different angles. And I always feel like we're having to borrow from Peter to pay Paul. So I already compromised moving MAT there.
Okay, so I'm hearing interest to leave them as is. And so then we would consider, let me get these boxed in here. We would consider these, apologies, I know that's a little bit hard to see that slightly thicker line there, but we would consider that 1, 2, 3, 4 recommendations. There's some big ones in there in terms of combined, but those 4 recommendations would be considered highest priority related to the topic of treatment and recovery. With those 4 on the table, I'd take us maybe one by one, and we can color them in for either candidates for immediate action or things of strategic importance that will that we need to start the legwork now, but will take longer to accomplish. And I'll maybe start us with the combined recommendation related to housing, the SOAR program, expansion of the SOAR program, and expansion of supported housing. Would the group consider that one for immediate action, or is that something of strategic importance that will take longer to accomplish?
Deb Stidham, I'm curious what Gary thinks from the state perspective.
Gary, care to weigh in there, looking at the recommendation in row 17? Would we consider that combined recommendation one of strategic importance, thinking it'll take some legwork and take some time, or is this a candidate for immediate action?
This.
Go ahead, Gary.
Carly, I'm sorry. I'm kind of dual working here, so
Understandable.
I heard my name, but I did not hear the complete question.
Yes. So we're looking at the recommendation in row 17 on my screen that we've just combined 2 housing-related recommendations, one for expanding the SOAR program and one for expanding supported housing. And the question to you is if you would consider that combined recommendation something around which we could take immediate action, thinking it could be completed in the next 2 years, or is it something of strategic importance that would kind of take some legwork and would be completed over a longer period of time?
Well, that's a very good question. I mean, I see the importance in this and feel like it's something we should give some significant emphasis to. But I also see it as something that we're going to need to work on for a while. But I still think we should put it probably a higher priority.
So I'm hearing higher priority, but it'll take some time. So I'm going to color it in green. Does that sound okay from the group, or is there discussion on that?
So again, thank you all very much for that.
Okay, thank you, Gary. And was someone else looking to weigh in there? I thought I heard a voice just before Gary started speaking.
So happy to do that.
This is Kelsey at KHI. I was just going to offer that I thought Gary would be tied up, and right now is the Children's Subcommittee's presentation to the Secretary. So I assumed was his delayed response. But
gotcha. Thanks. Okay.
Yeah, this is Gary. Thank you, Kelsey. Yeah, I was being asked a question from the Secretary in that group. So
oh boy.
Back and forth. It's almost over though.
Well, thanks for really hustling today, Gary, and multitasking for us. We appreciate your input.
No problem.
Okay, so the next recommendation that the group has labeled as high priority is related to PRTFs, and this is to continue ongoing work to improve care delivery and expand capacity. such as through reduction in the wait list and incentivizing reductions in readmissions.
So Lisa with Compass, I'll be selfish on this one and ask that it be yellow.
Okay, discussion from the group there, if we consider this a candidate for immediate action.
I think this is Gary from KDEDS. I think this is something that we are currently acting pretty diligently on. And I think I said this before, the incentives of reductions and readmissions is a bit concerning to me because I don't want children discharged before they're ready for discharge. And sometimes when we do incentives that way, the rush to discharge becomes more important than the ability or the necessity to, the things are ready for discharge. I agree that this is a high priority, but I also think this is something that is, we're just now starting to get a handle on the PRTF situation, and I really think it's going to be an ongoing issue for quite some time, but I'm okay with it being yellow or green, whatever the group feels, but it is something that a lot of work's been done, a lot of work will continue to need to be done.
Hey, this is Carly at KHI. Gary, can I just ask one follow-up question there to clarify a comment? So is there concern from your perspective with the language at the end of the recommendation about incentivizing reductions in readmission? I think how the group talked about that was aiming to minimize any incentives to like discharge youth before they're ready for discharge, but is there concern with the language around incentivizing reductions in readmissions? Does that need to be removed?
Incentivizing, to me, as I read that, makes me wonder, are we talking about, and I wonder if MCOs would be looking at the idea that, that there's some sort of financial incentive for there not being readmissions or keeping kids out, which, I mean, I want to keep kids out, but at the same time, I want to do it when it's appropriate.
So
maybe incentivize is not necessarily the appropriate word, but I think there's a lot of work that we can do outside the PRTFs that supports the need for readmissions.
That's right.
Yeah, Kelly from DCF, example, like in line number 41, kind of in my mind goes hand in hand with what we're talking about.
Yes.
And I agree.
Okay. And actually just got a comment from one of our staff people. Let me see where I can put this. That this is old language that didn't make it into this version of the draft. So how the group had talked about it.
Okay, good. Let
me see if I can copy. I'll read it to you. How the group had, I believe, talked about this previously. Was monitor ongoing work to improve care delivery at PRTFs to meet the needs of youth for whom PRTF is medically appropriate, such as through reductions in the PRTF waitlist, focusing on reintegration and discharge planning, being sure to include schools.
I like that a lot better.
Yes.
Okay.
Yep.
Apologies there. We just had missed pulling that language over, but it's not looking like I can copy from the chat. So I'm not going to be able to update that right this second, but with that new language, is the group still interested to consider that one yellow for immediate action?
So I have a question for Gary. Deb Stidham here. I hear what you're saying, Gary, about the work that's started and ongoing. I'm wondering if there is something specific that could go here for immediate action that would reinforce the work that you're doing.
I really think adding the language that we just added, I feel better about it being being yellow, in the sense that this is a big piece of what's been missing, and something that's been a huge part of the work we've done is what are we providing these kids before the PRTF, and what are we providing these children and family immediately after. So I think building up those services pre and post PRTF are certainly something that really needs to become a priority. So with changing the language, I certainly feel more comfortable with that. And, you know, especially with including the schools. Sometimes the schools are left out in that planning.
So where I was coming from, and the priority is 2 families. This is Lisa with Compass, sorry. 2 people in our area last week were just, I mean, the families were calling DCF to say, come take our kid. So if we can't get them in a PRTF, they're going to end up in a different placement, away from family, away from friends, away from school. I mean, it just creates a different problem. That's why I think PRTF's urgency is still there.
Yeah, Lisa, this is Gary. I agree. I think it's become a much bigger issue with COVID, because there's a lot of services that are not necessarily available that really we need to have available to kids and families. And it has created a gap there it's expanded a gap, I guess. The idea of, you know, what services they could have. I'm hopeful that as we deal with that and COVID comes to some sort of resolve, you know, but there's still a gap. So I agree. It's a priority. We need to get those services in place so that we don't have families feeling like the only choice they have is a PRTF or foster care.
Yeah, this is Kelly from DCF. And again, I think that goes right in line with line item 42 and that recommendation of the flexible treatment options. I feel like PRTF and the rest of the service array kind of go hand in hand.
Yep.
Very good. So then would maybe direct us to the service array high priority recommendation. How would the group like that one to be considered? Is the service array something that we'll be able to take immediate action on and complete that recommendation in 2 years? Or is this an item of strategic importance that we need to start the legwork immediately, but the change will happen over a longer period of time?
This is Kelly from DCF. I think it's going to be yellow. I mean, it needs to start immediately, but it's going to take time.
So it's green, isn't it?
Oh, sorry.
So green.
I agree with the green.
I agree with.
Gary,
Oh, sorry.
Gary from KDADS, I agree with green too.
This is Barbie Andrus. I agree with the green, but I was wondering, it was past conversations that I've been listening to. If we put a period after service array, explore options to expand the behavioral health service array, period, and then make this array available, you have 2 thoughts in there rather than 1 thought. And that's kind of what we were talking about, that we would enhance our service array, but we would also make it available to people. Does that make more sense, or am I off track?
So wanting to, what I'm hearing, the suggestion there is to tweak the language of this service array recommendation to more clearly articulate the 2 pieces, which are expanding the service array and increasing the number of individuals who can meaningfully access these services.
Yes.
Is that the 2 pieces? Okay, discussion from the group on that. I think I'm generally seeing nodding heads. Okay, rather than workshop that right now, I'm going to leave a comment here that we want to reword to put 2 ideas in 2 sentences, expanding services, and then increasing access. Okay. And then the last recommendation that you all have considered highest priority here is the one related to frontline capacity. How would you like to consider that? Is it one where we can take immediate action and we can complete this in the next 2 years? Or is it something of strategic importance that we will need to start now and work on over time?
This is Kelsey at KDHI. I'd say this is one of strategic importance. Like we have the grants we can rely on until I think it's 2023, but something that should be like on people's radar.
This is Gary from KDADS. I agree with Kelsey.
Deb Stedham, I agree too.
Very good. So that would take us to this set of high priority recommendations related to the topic of treatment and recovery. Want to give people a chance to kind of zoom out on this and let us know if there are any concerns looking at these as a whole, any additions or additional edits that we should make at this point.
Hey, Carly, just, I apologize. I'm going to have to jump off. I have something pressing I have to tend to.
Very good. Well, glad you could join us today, Deb. Okay, not hearing from the group any concern here, we will consider this the list that will go into a product for your review at a future meeting. We've got about 20 minutes left. So if it's okay with the group, I would like to get us started on a final agenda item, which is reviewing some of the Qualtrics results related to special populations. And so let me start that screen share. Okay, and actually we'll do a quick scroll here down to the end because I specifically, there was a couple of different items that were suggested as new recommendations in the survey. So I'd like to make sure the group is, I'd like to get the group's thoughts on those before we adjourn today. And then as a reminder, we will kind of have the prioritization conversation where we're reviewing all the scores and trying to identify highest priorities related to this topic at our next meeting. Okay, so this recommendation, at the end of our meeting on special populations, we kind of were thinking about what gaps, and we realized there were a couple of populations that we had no recommendations for, and we were kind of in the closing minutes of that meeting, so we didn't have time to unpack them. So we asked for input via survey, and the first of those populations was domestic violence survivors. And so the recommendation that came out through the survey for your consideration here is on the screen. And so that recommendation is to build awareness of and responsiveness to the behavioral health needs and risks of domestic violence survivors of all ages through data analysis, information sharing, workforce training, and targeted interventions between domestic violence providers, state agencies, and community providers serving individuals impacted by domestic violence. A few of the specific comments from the survey I've copied in there for your reference, but initial thoughts from the group on this draft recommendation. What changes does it need? Not hearing any changes, I might move the group into some further discussion around it. And so I guess the first question is like, is this recommendation, kind of our regular starter question, is this recommendation an important part of what it would take to have a modernized behavioral health system? Looking for a yes or a no there.
This is Gary from KDADS. I'd say yes.
Okay. Seen nodding there. So we will consider this as, one to be scored for consideration in the recommendations. Can I direct the group to the ease of implementation column? Can we describe this recommendation by checking any of those boxes here? What would it take to implement this recommendation? First, maybe what type of change would it require? Is this a program change, pilot program overhaul, et cetera?
Well, this is Gary from KDADS, and I think that we've got a couple different things here. possibly a pilot program and a new program. But I'm not as aware of all the programs for domestic violence as others might be.
Very good. Others care to weigh in there?
Carly, this is Rachel Marsh. I was thinking it was somewhere between a pilot program and a program overhaul, because I think it's probably more about connecting the different systems rather than creating a brand new system. So that would, I wonder if I don't know if you can check 2 boxes there, but it feels like it's kind of right in the middle. The pilot would be, how do you connect between the existing programs?
This is Carly at KHI. Thanks for those comments, Rachel. What about the rest of this column here? Any thoughts the group can provide? Maybe just check boxes. Which of the following mechanisms may affect the achievability of the recommendation? What types of systems would it have to engage with in order to move forward?
This is Rachel with Children's Alliance again. I'm not sure it requires any of those particular pieces. I would say it potentially needs an agency budget development, could be about contracts and systems to ensure, like that says their IT, those are always helpful in order to support program integration.
Mm-hmm.
This is Gary from KDADS. I'd agree with that.
Very good. And then is someone on the group willing to toss out an ease of implementation score for this recommendation? So as a reminder, a 9 or a 10 would be the things that are really easy to implement, and a 1 or a 2 would be things that are extremely challenging to implement. How would we score this recommendation? Anyone willing to toss out a number as a starting point?
This is Gary from KDADS. I'd say a 6.
Any discussion from the group on that?
This is Sunny from Blue Cross of Kansas. I agree with the recommendation of a 6. I think there are a lot of resources in the community, and it's just connecting them, as Rachel said.
Very good. Then would maybe direct the group to the potential for high impact column. How would you have me describe the impact of this recommendation? Maybe you could start with what checkboxes would you direct me to for special populations?
This is Rachel. I would say foster care and children, specifically, of course, domestic violence is often seen as between the 2 adult parties, but often it overflows into the mental health of children, sometimes to the extent that they end up in foster care or they can't go home because it's not a resolved issue between the parents.
And this is Gary from KDADS. I think we also need to include frontier, rural, urban, low income. I mean, this is a problem across the board. It's not just one particular area.
This is Carly at KHI. Gary, can I read into your comment then that you would describe this recommendation as one that would affect a large population?
Yeah, I would say it would affect a large, but when we're looking at, adults, children, folks across the board, I do believe it would be a large population.
Okay. See nodding there. And is someone willing to toss out a score for potential for high impact? So a 9 or a 10 is a very high impact recommendation. A 1 or a 2 would be a lower impact recommendation.
Gary from KDADS again, I think I would say an 8 or a 9.
Okay,
This is Rachel. I agree with that.
Okay. Very good. So I have an ease of implementation score for a 6, a potential for high impact score of an 8. Any other comments that I should capture whenever we're looking at this recommendation here?
Were we going to go ahead and check all the boxes under will it significantly impact special populations?
Yes, I can do that. Thank you, Lisa. Okay. Then I will move the group over to another recommendation that was submitted via survey at the suggestion of the group at the end of our last meeting. So this was the need to have recommendation related to children of incarcerated parents. So the draft recommendation for your review on the screen reads, build awareness of and responsiveness to the behavioral health needs and risks of children of incarcerated parents into the behavioral health system through data analysis, information sharing, workforce training, and targeted interventions and coordination between KDOC, DCF, KDADS, KHI, and the State Department of Ed, as well as community partners serving children of incarcerated parents. So first want to ask the group, what changes would you make to that draft recommendation? Okay. Maybe hearing that we like it as is. I'll see if we can do let me double check. I think this is our, yeah. So this is the last of the new recommendation. So I'll see if we can do a speed round of scoring it in our last 5 minutes here. So looking at the ease of implementation column, what boxes would the group have me check to describe this recommendation? Apologies, I'm struggling to get it all on the screen. How would you describe this recommendation for ease of implementation?
Carly, this is Rachel Marsh. I would again say it's somewhere between a pilot program and a program overhaul. I did just happen to have a conversation last week with someone who did this kind of work in Kansas, so it's not unheard of. It's just that we haven't systematized it or spread it across the state.
Very good. And Rachel, if you have thoughts, would you care to weigh in on which boxes should we check in terms of mechanisms that may affect the achievability? What systems or processes would we need to engage with there?
Sure. I think similar to the last ones, the contracts, agency budget development, and potentially grant cycles and systems. They're not necessary, but they could be helpful.
Good. And any interest to toss out an ease of implementation score as a starting point here? Again, 9 or 10 being very easy to implement, 1 or 2 being significant challenges to implementing this.
This is Gary from KDADS. I'd say with the amount of interagency work we're looking at least probably a 5.
Okay, discussion from the group on that? Okay. Moving us over then to the potential for high impact, how would we describe this recommendation? Maybe start with which special populations might be significantly impacted here.
This is Rachel, just in your speed round here. All volunteer foster care children and low-income individuals at least.
Well, this is Gary from KDADS. I think we're in the same situation we were in the last one, that this is going to affect people from all sectors.
So Gary, I'm hearing that I should select frontier, rural, and urban there.
Yeah.
Okay. And would the group consider this recommendation one that would benefit a large population?
This is Kelly from DCF. I would say no.
Okay. And anyone willing to toss out a potential for high impact score for us? 9 or 10 being a very high impact, 1 or 2 being a smaller impact.
Gary from KDED's, the folks we'd impact, I think it would be significant. So I'd want to say a 7 or 8.
Okay, drop a 7 in there. Any discussion from the group on that?
I'd agree with that. This is Rachel again.
Okay. Very good. Well, I guess I'll pause there and see if there's any final comments that we should note in regard to this new recommendation here. Okay, not hearing any. Let me turn off that screen share. I want to thank everyone for your work today. We really covered a lot of ground and it was so helpful. We have our high priority recommendations related to the topics of prevention and education, as well as treatment and recovery. At our next meeting, we will do the same thing as far as getting to our high priorities related to special populations. So as a reminder there, we still have a little bit of review to do of some Qualtrics responses, just in terms of checking in on those scores and making sure they make sense to the group. And then from there, we'll move into the identification of those highest priority recommendations. As far as other next steps for the group, what our team at KHI is doing as we identify the high priority recommendations is we're translating that into what will be the working group product to the special committee. So taking these high priority recommendations, pulling in all of the discussion notes from our previous meetings on the topics, as well as background information from any past reports, and putting that together in something that looks like a product. You all will receive that product, and we will review it ahead of the special committee meetings on December 10th and 11th is where they will review the working group product. But you all, as members of the working group, will see and have the opportunity to provide comment on that product ahead of those meetings. I want to quickly just check to see if there's any questions from the group about the work that we've done today before we adjourn. Okay, not hearing any. Thank you again, everyone, so much for being on the call and weighing in today. Want to extend a special thank you to Barbara for lending us her expertise for the day and weighing in. So with that, we are adjourned. Thank you, everyone.
Thank you.